Hello everyone, it is 12:30. It's actually I think maybe 1 minute past, so we are going to go ahead and get started. We've got lots to cover today. Thank you all very much for joining us. A few housekeeping slides and then I will introduce our speaker. As you heard when you logged in, all the phones are muted on our end until the very end, in which time we will unmute for questions. If you're listening to this as a live webcast or as a recording, you can get Category 1 AMA PRA credit. I will tell you how to do that at the very end, so stay tuned till the end to figure out how to do that with either the survey in your webinar appointment or in the notes section for the video. For questions, you can use the chat button at the top right-hand side of your screen. Find Alex. You can send me your messages, and I will ask the presenter if they're urgent. If not, we'll wait till the end. And also, again, at the end, we will unmute the phones for questions and discussion. This is my contact information should you want to ask me any questions or suggest any topics. If you're having any issues with any of our services or want to join our outreach network or refer someone to our outreach network, please use this email address here, outreach@CarellianClinic.org, or you can call our office number right here. Also, a quick plug, we do these 30-minute kind of bite-sized topics once a month. We do weekly pediatric grand rounds. We have one coming up this Thursday. We store everything that we can record on our YouTube channel. We are moving away from the Carelian Clinic channel to our own channel. It's called Carelian Children's Outreach Education, and that's where we'll be putting all of our videos. We'll be migrating all of our older videos from the Carelian Clinic channel to that in the next few months. And then we always invite you and any of your colleagues, peers, staff to join our outreach network where we do these webinars, recordings, send out communications for local issues by local experts, and it's all free. Today we have a very special guest in our kind of ongoing series about child sexual assault. We have Christina Rouse. She has a master's in social work from Radford, has been in the field for 10 years. She is currently at Children's Trust. She is the Program Director for the Child Advocacy Center and the lead forensic interviewer. And with that, I will go ahead and turn it over to her for the presentation. Thank you all very much for joining us.
Great. Thanks, Alex. So I have quite a bit of information for you all for the next 30 minutes. So at times I may speak quickly just to ensure that I get through the entirety of the content for you and hopefully leave some minutes at the end for questions. Just because I've been working at Children's Trust and interviewing children primarily who have been sexual abuse victims, I tend to go off topic just because all of the information is really good information, and I find it very important to educate community members, professionals in the field that are working with these victims, give them an overview of kind of what to expect and what they may see in the field. So with that, if I go quickly, this is archived, so you may have to listen back to it to get all of the information. Obviously, this is my disclosure. Okay, so a lot of times people don't really understand the importance of statistics and research in regards to the kinds of cases that you're working with. I geek out a little bit in regards to statistics and research, so I find numbers very fascinating. And I always think it's a good idea to know kind of the baseline of where you're at to understand the picture that you're looking at. The problem with sexual abuse statistics is we're only getting data that's actually reported. And as you all know, child sexual abuse is the most underreported kind of abuse that there is. So our data snapshot that we get seems to be on the low end, but again, these are just kids who have actually come out and have made disclosures. The national statistic right now is that 1 in 10 children would be sexually abused before the age of 18. It used to be 1 in 4 girls and 1 in 6 boys, but they kind of generalized it a little more. I think that's pretty profound if you think about all of the children in your own lives or kids that you've come into contact with, and just that number of kids that have experienced sexual abuse. Most of these kids, again, aren't talking about their abuse, so these are kind of our silent victims. I've broken down kind of the kids that we've seen at the Children's Advocacy Center by jurisdiction. Our Children's Advocacy Center serves Roanoke City, Roanoke County, Salem, Radford, Bedford, Montgomery County, Pulaski, but we also see a lot of outlying jurisdictions that bring their cases to us. Bedford, Botetourt, Craig. So this is just a very small snapshot of the kids that have come into our center who've made allegations of abuse and neglect, primarily sexual abuse, that we've conducted forensic interviews for. And I'll talk a little later about the process of what happens with a case once it gets reported and the Children's Advocacy Center and how we get involved. Overall, in Virginia, over 2,000 children had child sexual abuse investigations in the state. And again, you may think that this is a very low number, and that 2,000 caseload represents about 10% of the totality of cases that the Department of Social Services actually investigated. So the whole idea of us talking about child sexual abuse today is that people don't hear about it. If you think about the last time you heard of a child sexual abuse case in the media or in your community, it was probably a long time ago, or maybe one, not a lot. Child sexual abuse is not reported, and most people don't want to talk about it. The stigma attached to child sexual abuse, whether that's the victim or the offender themselves, people just would much rather turn their head, close their eyes, sweep it under the rug, than acknowledge that this kind of abuse happens in our own community, and it's happening every day. The scary thing about child sexual abuse is it's evolved over the years. And if you were a product of the 80s or grew up in the 80s, it was all about stranger danger. People in the bushes, men in trench coats, these were people that we thought were our offenders on our kids. In actuality, about 85 to 90% of our perpetrators in child sexual abuse cases are family members. It's an intrafamilial type of abuse, meaning that most of the time it's parents, step-parents, parents, paramours, boyfriends, girlfriends of mom and dad, grandparents, essentially any individual, especially an adult, who has a relationship with a child. The closer that relationship is, the higher risk they are of becoming a victim of sexual abuse. So when you think about educating our own kids about being aware of offenders, it's not stranger danger anymore. So I would hope that we like to get away from that speech to our children about don't talk to strangers. In actuality, it's kind of like a dual message. You tell your child not to talk to a stranger, and then you go through the McDonald's drive-thru and you're talking to a stranger. So kids don't quite seem to understand that. So we need to be more aware about the adults that are having contact with our kids, specifically in the family. The other thing about child sexual abuse is it's very secretive in nature. These offenses aren't happening in public. They're typically behind closed doors, and there are usually only two people involved, the offender and the child. And if that child's relationship with the offender is close, let's say it's a parent and a daughter, no one would question why that dad is behind a closed door with their child. So it's very secretive in nature. It's also very secretive in the sense that kids aren't aware of what's happening, especially if it's a younger child. Their worldview of sexual interactions is non-existent. So things that happen in regards to child sexual abuse, they don't understand that what that is wrong or not okay. So it's very secretive in nature. Again, there's no witnesses. In my experience, we have never had a case where an offender has brazenly sexually abused a child in the presence of another individual. So this fact that there are no witnesses make these cases very extremely hard to work because you're going off of what the child has disclosed to you. And if you put a 4-year-old against an adult in the community, let's say that adult offender is a prominent community member, the reality is most people are going to believe that adult over that child. So not having any other type of evidence or corroborating evidence makes these cases very hard to prosecute. If you think about child sexual abuse, it's not just physically abusive. And in actuality, most child sexual abuse cases, there are hardly any physical evidence. I think right now the statistic is 3% or less of cases have any physical findings from child sexual abuse. And I know Heather Smith, who's one of our forensic nurses, just talked about child pediatric forensic exams and how there's hardly ever any physical evidence. So we don't think about a child sustaining a physical injury in sexual abuse cases. Whereas if you have a physical abuse case or a neglect case, there's typically a lot of evidence to go hand in hand with that actually occurring. It's both mentally and emotionally abusive for our kids. We're going to talk about the disclosure process and some of the systematic things that happen to children as they experience sexual abuse and how they process that sexual abuse that have long-lasting impacts that can be extremely detrimental for them moving into adulthood. The biggest thing to think about and remember about child sexual abuse is that when a child discloses abuse, that's the exception. Most people don't ever talk about it and don't ever report it. So if you're in a situation where you have a child or you have a patient that is disclosing or is making some type of disclosure to you, that's gold. That's super important to take that and kind of build our case off of. So just remember, disclosing is the exception rather than the rule. So as I mentioned before, child sexual abuse, you can't put every victim of child sexual abuse in the same box. Every child is different. How they present as a victim is going to be different. The variables that go into play in their victimization is going to be different. And where they are in their disclosure process is going to be different. So a lot of times we get the questions of, well, is she a typical sexual abuse victim? Well, there is no typical sexual abuse victim. Every kid is different. So if you've already have in your own mind a child that you think about as being a sexual abuse victim, completely erase that vision of what that victim looks like, because every child is different and it's always changing. These victims are always presenting in different ways. So when a child does decide to disclose, there are two ways that typically happens. There's accidental disclosures, which are essentially information is revealed by chance. And then there's purposeful disclosures where children are making that conscious decision to tell someone about what they're experiencing. The sad thing is that the ratio between accidental disclosures and purposeful disclosures is about 70-30. So most of our disclosures we get in regards to sex abuse are accidental. These aren't kids who are making that conscious decision to reach out to someone and tell about what's going on with them. Most of the time it's an accidental scenario. For example, if you have a young child, perhaps 3 or 4, who's playing with their toys and is putting their 2 Barbie dolls in compromising sexual positions and is making one doll do a sexual act to another doll, and the parent sees this or is observing this behavior and says, hey, what are you doing? And the child may say something like, this is what me and Johnny do, this is what me and Sarah do. That's an accidental disclosure. That child is not consciously deciding to tell an adult that, hey, this is happening to me. It's more of them just happenstancing, filling you in on information. A lot of times we see these accidental disclosures with children who have sexual behaviors beyond their developmental age range. That's typically a large group of those kids. And then we have our purposeful disclosures. These are children who seek out an adult or a trusted individual who want to tell about the abuse that they've endured. Most of the time, these purposeful disclosures are coming from our older kids, our teenagers, and a lot of the times at that point, they make that conscious decision to tell to make the abuse stop. They just want it to be done and over. A lot of times, these purposeful disclosures also come in situations when there are other siblings in the home. So the child who is being victimized purposefully decides to tell because they want to protect their other siblings from becoming victims as well. So once a child decides to tell, which again, emphasizing the importance of how magical those moments are when they make that decision to tell, they still go through different stages of disclosure. So there's denial, tentative, active, recanting, and reaffirming. So obviously, denial kids will adamantly deny with every fiber in their being that it didn't happen. So this may be a situation where someone did walk in on a sexual act or crime being committed on a child, and there's evidence that something did in fact happen, that child will still adamantly deny that anything happened to them or that anyone touched them. We've seen this a lot in cases where there have been photographs or video images taken of the sexual acts where we know there's hard evidence that these kids have been victimized. Sometimes these kids still deny that they were abused. Another stage of disclosure is the tentative stage. So these kids may say some information about their abuse, but not all the information. These are children that typically say, I forgot, or it was a long time ago, or I don't remember, when you start to try to ask additional questions from them. Young kids may even say, I was just kidding, or it didn't happen to me, it happened to my brother. So again, they're divulging, but they're not providing the totality of their experience. Active disclosing kids, these are the kids that typically have that purposeful disclosure. They've made that conscious decision to tell, and they're actively telling all of the information that they have about their abuse scenario. Again, unfortunately, children, a small percentage of children are ever in the active disclosing phase, and we'll talk about some of the barriers they experience when they do disclose. Recanting, a child tells, and then for whatever reason, whatever variable existed, they take back their original telling of the story. This is a huge population of our children. Most often, I always anticipate a recantation happening when we're dealing with child sexual abuse cases. And we'll talk about why recantations happen when we talk about the barriers. Typically, it's due to the lack of support of the non-offending caregiver. Reaffirming, these children tell, they recant, and then they come back and reaffirm their original telling of the story. The really difficult part with children who recant and who reaffirm is their question of credibility has already come into play by the system as a whole. Whether that's investigators or prosecutors or the public at large, these children already deemed to be not credible because they took back their initial disclosure. I would like to implore everyone to not be swayed by children who recant or reaffirm their abuse. I actually find those kids more credible just due to the variables that take place. So the other thing about disclosing is a lot of times we get cases where we jump to conclusions. We hear pieces of information, whether that's third party or from a child's disclosure to ourselves that doesn't quite make 100% connection for us, where we jump to conclusions that that child was in fact a victim. And so then when we start going into the information with the child, we may get denials, we may get some tentative things, where in fact no abuse actually occurred at all. So it's really important for our mandated reporters and our first responders to engage with these children in an appropriate way so that we're not chasing a rabbit down a rabbit hole when we don't need to. So young children under the age of 5, they are really good tellers of their experiences if they have seen something, if they've heard something, or if they've experienced it with their own body. So a child who has an accidental disclosure, maybe they have some sexual knowledge that's beyond their developmental years, and someone's concerned that that child may have been victimized sexually. That may be true, but that may also be a case of a child who's being exposed to inappropriate language or inappropriate images in the home. So they've seen sexual things, but they themselves have not been physically sexually abused. So we always want to keep our minds open to what these kids are experiencing. So there are 2 models that came about mid-80s in regards to how we understand children's coping mechanisms of how they've experienced their victimization. The first one is the Child Sexual Abuse Accommodation Syndrome, and this was put out by Dr. Roll and Summit. And when he termed the COIN syndrome, he was doing a good thing. This is not a medical syndrome. It's not diagnostic. And so he kind of got a lot of backlash in regards to that because you can't label someone with having this accommodation syndrome. Essentially, the accommodation syndrome just helps explain the experiences that children go through. So they're coping behaviors of children that they experience. So secrecy, helplessness, entrapment, delayed disclosure, and retraction. The sad thing with coping behaviors in children is they typically don't meet adult expectations. So we as adults don't understand why a child may do certain things if they're experiencing child sexual abuse, because as an adult, I wouldn't behave that way. So why is this child not doing what an adult would do? So it feeds into that disbelief and non-credibility of children because their coping behaviors don't make sense to us, which is sad because that results in further abandonment of these victims, which then drives victims further into self-blame, alienation, and potentially re-victimization themselves. So just because a child discloses abuse to you and how they dealt with that abuse before they reported doesn't make sense to you as an adult, don't negate their disclosure. It's really important to understand that sexual abuse, again, is going to be different for every person, and how a child takes that abuse and processes it may look unusual. So obviously with secrecy, these are the phases of the abuse when everything is done in secret. Basically, it's the source of fear and the promise of safety. So these are parents or offenders who tell the child, keep it a secret, don't tell anybody what we're doing. And again, it goes back into sexual abuse in general. It's secretive in nature. And typically with the secrecy, there's some combination of a threat or guilt or shame that make that child keep that secret. A child who's experiencing helplessness, these are our young kids again, they rely on adults to keep them safe and feed them and nurture them and house them. And so they may feel helpless in their abuse. That's what's happening to them. They don't have the power or the authority to change their situation. So their helplessness in what is going on, a lot of shame and self-blame come into the forefront with helplessness. They may think that what is happening to them is their own fault, or they brought it on themselves. So they have a lot of those feelings. We see a lot of helplessness when we have offenders who are in authoritative roles. So coaches, mentors, a teacher, someone who has an authoritative role. Most often these kids feel extremely helpless in their victimization and are less likely to disclose. Entrapment, these are kids who typically have ongoing abuse, more than one incident, and it's typically the same style of abuse over and over again, and they feel that their only coping mechanism is to embrace what is happening to them. And this is the biggest one that doesn't make sense for adults. So I'll give you a case scenario. A 15-year-old victim was being sexually abused by mom's boyfriend, and this abuse occurred every day when mom would go to work in the evenings. Mom would go to work, offender would come into her room, sexually assault her, leave. And that happened multiple times over and over and over again. And the biggest question would be, why didn't you tell? Why didn't you do something to stop it? You knew that he would be coming into your room every day when your mom left for work, so why didn't you change your scenario? She felt helpless. She felt trapped in her environment. A lot of times entrapment includes kids who previously tried to disclose and it didn't work. So those are hard cases to figure out. The delayed disclosure, these are kids who are maybe in their teenage years disclosing abuse that happened when they were kids. Why didn't you tell? There may have been lots of situations why they didn't tell earlier. Maybe they did try to tell earlier. No one believed them. So delayed disclosures are really hard cases to work as well. And then obviously the retraction cases where the kids take it back. The other model, the traumagenic model, is very similar to Rowland Summit's. It includes betrayal. The traumatic sexualization, that one's really important because that's where we start folding in those emotional and mental injuries in regards to kids, where that disconnect of what a normal, healthy sexual relationship should look like gets rewired in their brains and becomes a traumatic sexualization, and the powerless and the stigmatization we see a lot of times as well. So when we talk about why kids don't disclose and we talk about barriers, this is a really nice infographic or Venn diagram to kind of pull it all into place. So obviously if a child has any disabilities, whether that's their physical disabilities or mental disabilities, they're already at a higher risk of becoming abused, first of all, but they are much more likely not to be able to disclose, especially if their disability has anything to do with speech or cognitive function. If a child can't tell what's happening to them, they're in a situation where their abuse never may be uncovered. The biggest blocks that we see in the field when we're investigating these cases are familial blocks, and interviewer-induced and perpetrator-induced. So some familial blocks would be the non-supportive caregiver and the disbelief of the child, people not believing what the child is saying, especially if a child discloses and that person who they've disclosed to says, shut your mouth, we don't talk about that kind of stuff. That child's most likely never going to tell again. So any special needs, if they're hard of hearing or if there's a language barrier, that's a huge issue. Perpetrator-induced, these are the threats, the bribes, the coercions. If you tell, I'll kill your dog. If you tell, I'll kill your family. These are real things for kids. And so that threat, just that sentence alone, keeps a kid from telling. Our interviewer-induced, that's ourselves. So what bias do we bring to a case? Am I wearing my police uniform? Am I wearing my gun when I'm trying to talk to a child? All of those things fold into a barrier of whether or not a child's going to disclose any information to us. So kind of reiterating, a child is more likely to disclose if they have a supportive caregiver, they're in a structured environment. The further the relationship is from the offender, so if it's a stranger and a child, they're more likely to disclose. As that relationship gets closer, so parent to a child, they're less likely to disclose. There was a one-time incident, and female victims tend to disclose more often than male victims do. What kind of decreases the likelihood of disclosure is that non-familial support, that close relationship, multiple incidences, so chronic abuse over multiple years, previous attempts to tell someone that something's happened to them, and the threats and the bribes and the coercion. Those are big key variables when we talk about these cases. So obviously it's important that we understand how kids process child sexual abuse, because then we know how to approach these kids. You know, the big hot topic thing now is trauma-informed approach, trauma-informed care with our victims. If you don't understand how kids are processing child sexual abuse, and you have that kid sitting in front of you or that patient sitting in front of you, you're not sure how to handle them or even take what they're saying with any credit or merit. So we have to know how they've experienced their trauma and how they're processing it in order for us to approach them in the best way to help understand what actually happened. So we do a really good job of educating our first responders and our mandated reporters on a minimal facts interview prior to an investigation starting. This is kind of your tipping point for, or your kicking off point on how to start an investigation. But the minimal facts are our WH questions, our what, where, when, who. It's really imperative that our first responders or even the people that a child discloses to aren't giving kids full interviews. Those happen later in the investigation. So especially if a child's not volunteering any information, you don't want to be asking a lot of questions to them. And most of the time, other information can be gathered from other sources, such as the person the child initially told, other people in the family. So it may not be necessary to actually talk to the child victim on scene at that time. So just a couple of tips for individuals if you do have a child that discloses to you in your realm of work or in your profession. The biggest thing is we need to remain calm and control of our feelings. Kids are very intuitive and can kind of read adults very well, and if we have a look of shock or surprise on our face when a child tells us things, we're sending a message to them that these are things we shouldn't talk about. And so we need to kind of put our poker faces on and really allow that child to tell us things in a neutral manner. We have to listen very carefully to what the child is saying. If you have an opportunity to write down that child's initial disclosure verbatim, I would highly suggest doing that. That initial disclosure is the most reliable piece of information we have to go off of. It's okay to tell the child it's not their fault. Depending on the age of the child, you may want to let them know you're going to have to make a report or tell someone else whose job it is to keep them safe. And obviously, if the opportunity arises to give them privacy, you want to make sure you try and do that. There are obviously things we don't want to do when a child discloses abuse to us because, again, the process works. The investigation will take place after that child leaves your office. So we don't want to ask the child any direct questions about the abuse. As a mandated reporter, all you need is a suspicion that something's happened to make a report. You don't need to know the details of who and the what and the how. It's not relevant at that point. Don't make promises you can't keep. Obviously, as humans, we're nurturing species, and we want to make sure kids feel safe. And so sometimes we say things like, I promise that won't happen to you again. But in actuality, we can't promise that. The judge can't even promise that. So don't make promises. Don't push a child into giving details about the abuse when they're not ready. This could be very detrimental later on down the road if that child has multiple interviews. Depending on who's talked to them, how they were talked to, could lead to misinformation and miscommunication. And obviously you don't want to discuss the disclosure with anyone not directly involved with helping the child or that case. So if you're listening to this webinar, I assume most of you are mandated reporters. There are some states in the country that every individual, every community member is a mandated reporter, which I think is fantastic. I think it's our responsibility to protect our kids in our community, but all you need is a suspicion of abuse. I like to kind of use the tagline of when in doubt, just check it out. You're not going to be in trouble for making multiple calls about a concern of a child. You want to make sure you call the Department of Social Services or law enforcement. If it's a case where the offender is not a caregiver, Social Services doesn't get involved in those cases, but law enforcement does. If you want to do diligence, you can call both entities and let them work it out. What I will say is in the system of investigating these cases, Social Services and law enforcement work hand in hand in all child sexual abuse investigations. So the Children's Advocacy Center is really the hub of the wheel that brings together all of the investigating agencies that work these kinds of cases. And we work in a multidisciplinary team approach. So investigators through DSS, law enforcement, the prosecutors and prosecuting attorneys, our mental health folks, our victim witnesses, our forensic nurses who provide our medical. We're all working these cases together in a coordinated effort to ensure that that child goes through the system in the best way appropriately. A lot of times these cases, like I said, are hard to work, and so we're all there working the cases hand in hand, jointly sharing information that's relevant to the case to ensure that that child has a positive outcome. Now, when I say positive outcome, I don't mean we put offenders in jail every time, because we don't. But what I mean is that that child was put first throughout the investigation. Their needs were put first to ensure that they potentially are put on a path of forming into a healthy adult as possible. This infographic just elaborates how efficient children's advocacy centers are. What I love is that the prosecution rates for cases that go through the Children's Advocacy Center or the prosecution rates that have multidisciplinary team approaches are higher than cases that don't. And that makes sense. The more coordinated an effort is when investigating child abuse cases, the better outcome for everybody. So to kind of wrap it up in summation, the bottom line is if you're in a situation where a child discloses to you, do minimal facts if it's appropriate. However, if a child says, you know, Daddy touched my pee-pee, there's not much more you really need to know from that, so go ahead and make the call as a mandated reporter. Getting the minimal information you need without tainting the investigation. Kind of staying in your lane, staying in your box, that's really important. And always, always keep the best interest of the child in mind, and following best practice is important as well. So I think that wraps us up. There are additional resources in there that you may look at as far as children's advocacy centers and just some national statistics and some research articles. Again, if you like to nerd and geek out about those things, those 2 articles at the bottom are really good to kind of help add up how kids process child sexual abuse.
Okay, thank you very much, Christina. I know that was a lot to cover, and I know that you usually probably could talk for quite a long time about that, so thank you for trying to condense it down. I think you have your contact info here on the next slide, yes? So if there are questions or if someone wants to have kind of an extended conversation after this, you're open to receiving communications through that. I will go ahead and open the phone lines up here real fast. I know we're a little bit over, so if you have to hang up, it's okay. If you want to get your CME credit, just fill out the CME link that's in your calendar appointment. And for those on the recording, I'll cover how to do that at the very end here. So I'm going to go ahead and open the phone lines up for any questions or comments, discussions that the listeners have.
The conference is now in talk mode.
Okay, so we're in talk mode. So if you are listening, please just go ahead and mute your phone. That way we don't hear what's going on in your background. But does anyone on the line have a question for Christina? I'll click it over. Okay. I did get a couple of comments coming through already. I know that someone had a question about where child advocacy centers are located, and I saw you had a kind of a link here. I'll backspace. Do you want to spend just a minute or two talking about how people can find out if they have a child advocacy center in their area, how they function, how they're funded, and stuff?
Sure. So I did include it in here. The Children's Advocacy Centers actually have a state chapter, and so you can go on their website, which is www.cacva.org, and there is a nice interactive map of Virginia that highlights where all of our centers are. There are currently 16 centers in the state of Virginia that are nationally accredited, which is great because we're adhering to best practices. And that's the easiest way to find out if there's a CAC in your locality. The ones closest to us is obviously our office here in Roanoke. We have a satellite office in Christiansburg. Rocky Mount has their own Children's Advocacy Center, and then you have to go down to Bristol to get the next closest one, and up to Stanton and Harrisonburg and Charlottesville. So that's kind of a good coverage area.
Okay, great. Are there any other questions or comments that anyone on the line would like to make?
Hey, Alex, this is Lori Dudley. I have a question.
Hi, Lori, go ahead.
I just want to confirm 2 things. One, certainly for kids who get interviewed there, that the police or DSS starts that process. We don't refer kids to the Child Advocacy Center. Is that correct?
Yes, thank you for making that clarification. So in order for us to interact and give forensic interviews to children, we have to have an open case with law enforcement and social services. So they would be the ones that already have that report in front of them, and then they make that contact to our services for the forensic interview. So you guys would call DSS and law enforcement, and then they would take the ball from there.
Okay, thank you. And one more thing. After the child has been interviewed and whatever happens, do you guys there at your facilities or some of the child advocacy centers offer therapy for children and families, or is it just sort of forensic diagnosis? Or
So the forensic interview is actually just kind of a fact-finding interview. So if you think of us as conduits to gather information of what happened to the child, we pass that information on to law enforcement. So our forensic interviewers don't actually make any determinations on whether something did or did not happen. We just gather the information from the child in the most developmentally appropriate way and ask questions that can stand up in court. Once that process is over, we have family advocates on site that are working with our non-offending caregivers that make referral for mental health services. So we don't have mental health on site, but we do work closely with family services, family preservations, and Blue Ridge Behavioral Health to ensure that these kids get hooked up very quickly to the mental health services.
Wonderful. Thank you very much. It was a wonderful talk.
Thank you very much for that question. Any other questions or comments from the line? I'm looking here. I don't see any additional questions from our online portion. So I think with that, we will go ahead and wrap this up. If you are still listening, I'll go ahead and go over. Don't forget to, if you want your Category 1 CME credit, you should have gotten a calendar appointment, which is how you logged onto this. If you scroll down in that calendar appointment or click on the Show More Notes on your phone, you should see a CME link. That takes you to our survey. You fill that out. All that information gets dumped into our CME tracker system that our CME department runs. It usually runs a few weeks behind, so if you log on looking for something to happen today, you probably will not see today's lecture on there for a couple of weeks. But you can go to their CME website, which is here, CorellianClinic.org/continuing-medical-education. Paula, I think you're on the line. We've got to do something to shorten that up a little bit. You can find the CME tracker system there to make sure you're registered so you can go on and see that. If you're listening to this as a recording from our YouTube channel, if you click the Show More Notes, Show Video Notes, that will drop down and you'll see the link to our survey that you can do, and you can go onto the same site here, the CorellianClinic.org/continuing-medical-education, to also log into your CME tracker. They all funnel into the same system. You just have to find the link in different spots. So with that, again, thank you very much, Christina, for being here. I know this is a awfully hot topic and a timely topic, so we're going to discuss as soon as we hang up how we get you guys back here to do more of these, because I know everyone is very interested in the information. But with that, we're going to go ahead and wrap up today. Thank you all very much for joining us, and we will see you again next month.